What is happening, man? Welcome to Tuesday Training. As always, I am here every Tuesday at 9 a.m. Central for your viewing and training pleasure. We've got mostly some news updates that I want to run through today, and then kind of just some random nuggets of wisdom here and there. But we do have quite a bit of news, and as always, I am focused on the Medicare space. So bring a lot of Medicare news for you today. Thanks for tuning in. As always, everybody, if you don't already know, click the link above in the description. That will allow Facebook to view your StreamYard comments. I think that's how it works, or maybe it's allowing StreamYard to view your Facebook comments. I forget. But what it does allow you to do is not be anonymous like Miss Luz Moon, who's always tuning in with us, versus Facebook user. I have no idea who that is. But he's ready to do it. I'm ready to do it too. So thank you guys, as always, for tuning in. Mr. Figler hanging out in Germany today. Wow. I don't know what brings you to Germany, but man, that is probably a pretty cool place to go. I've never been. I've always wanted to go. I have had friends that have gone to Germany, and they've brought back pictures of all the castles and everything that they've seen over there. So it'd definitely be a cool thing, man. Have fun, Mr. Figler, and thank you for tuning in. As always, this show is brought to you by MetaZeus. Man, if you're a Medicare agent out there and you are not familiar with MetaZeus, you need to get familiar because this is a phenomenal tool that is getting around the campfire quickly. And what it does very simply is it allows you to monitor your Medicare Advantage and prescription drug business pretty close to real time. If you're out there writing Medicare Advantage or drug plans, you know this already, that usually you don't find out when a plan gets flipped or canceled for maybe 2 to 3 months when that carrier finally gets you a chargeback. But MetaZeus allows you to monitor in real time. All you need is 2 pieces of information. You need their date of birth and their Medicare number. If you've got that, you can find out what their current plan is, what their future enrolled plan is, and the effective date. You can also find out what their LIS level is, which is helpful. So I'm a big fan of it. We used it this last AEP, saved us 7 applications, put that $2,100 and change back into our renewal stream. We didn't lose the business and certainly paid for MetaZeus. So if you're interested in it, give our buddy Evan McGuffey a call. He is a member here in the group. He can get you a demo and check it out, but I promise you, it is a super, super easy tool to use and very useful. I've heard quite a few people that are using it and really enjoying it. But with that said, we are going to jump right into it with some news today. Let's go right off the bat right here. Boom. Now, I didn't watch the State of the Union for, my own personal reasons, but this is pretty big here. Biden signs a $460 billion with a B spending bill that includes the doctor pay bump. I spoke about this recently, that they were proposing this, and it also includes a delayed DSH funding for Medicare, or DSH cuts, for community health funding. Medicaid DSH is the disproportionate share hospital, if I remember correctly. It's basically requires providers to proportionately treat people that have Medicaid versus other insurance, et cetera, et cetera. So they had originally, and I'll dive into it here, they'd originally have a giant cut on the board for that, but they are now delaying that and pushing it off. So let's dive into it real quick. Scrolling down in this article, I'm not going to go through the whole thing, right? We're not going to go through the whole 1,050-page deal, but if you want to look it up, I'll get this article in the group. You can click that link. It'll pull up the whole 1,050 pages. You can look at the entire deal. But the main thing for our concern that's in there is right here in this paragraph. And I've talked about this before. There have been some Medicare provider payment cuts that have happened, been proposed, etc. And they changed that to include a bump in Medicare physician payments through the end of this year. So if you read this little paragraph that I highlighted here, it says for healthcare, the latest agreement blunts the doctor pay decrease that was enacted earlier in 2024 through the Medicare physician fee schedule final rule. And that original fee schedule has a 3.3% decrease in provider payments. I mean, that doesn't sound like a lot of money, right? But when we're talking billions of dollars, that is a pretty big dent in doctors and hospital provider payments. So that physician fee schedule, right, they had it slated for a 3.37% decrease, which went into effect this year. But they did a couple of things, and they ended up pumping in a bump that will run through the end of the year to kind of stave off that whole decrease. So while there is a decrease for Medicare physicians, they're not experiencing it right now. But come 2025, they should definitely see some decreases in Medicare physician fees. And that is fees that are paid under original Medicare. This doesn't include Medicare Advantage plans or any of the other stuff. This is just doctors that are accepting original Medicare. They are earning less. They will be definitely earning less in 2025 unless some other laws come in to change it. But as it stands, they're going to get some reprieve through the end of this year, and then that decrease should go into full effect, barring any other changes by 2025, which could lead someone to pontificate, if you will, or speculate, I should say, that maybe fewer doctors might accept original Medicare next year. Maybe we'll see a decrease in that because of this. I don't know. That usually doesn't necessarily happen, but certainly could happen. And it will definitely make doctors, or it will make Medicare Advantage plans more attractive to doctors, considering they might be earning more through Medicare Advantage plans than they would be through original Medicare. Now, the next piece in here that is does affect us somewhat is an $8 billion per year cut to Medicaid DSH program payments. That was supposed to go into effect, and now they are pushing it off again to January 2025. Right? So the hospital sector stands to gain from this extension for the higher inpatient payment adjustment because, as we've discussed before on this show, we are seeing we're seeing a huge increase in the last year or so, couple of years really, of utilization. We've seen a big increase in utilization. People with elective surgeries that are now getting those surgeries done now that the pandemic is over, right? There was a bunch of people that were delaying their elective surgeries through COVID because they didn't want to go in there and get sick, right? So now all of those people are using hospitals and providers to get those elective surgeries done. So we're seeing a big bump. That's where I talked about last week a lot of with the Medicare Advantage plans that are posting losses, big losses in fourth quarter, et cetera. And we're going to hit some more on that a little bit later. But basically, this giant cut in Medicaid, $8 billion cut, that's pretty big. They're going to push that off till next year, which is going to be interesting in how that may affect the Medicaid unwinding as well. And we're going to touch on that real quick. As a matter of fact, I think that is the next one up. No, not quite. But this came out from Kaiser Family Foundation, and this gets deep into how Medicare pays its physicians. And this is, again, payments made under original Medicare. This does not include Medicare Advantage plans. Okay, we're strictly just talking about original Medicare again. This is a deep article. I am not going to go through all of it, but it goes through the timeline of cuts. It goes through the timeline of increases, exactly how doctors are paid, how that physician fee schedule works, the conversion factors, et cetera. And then they do show this little timeline here from 1985 to current that shows some of the different Medicare reform legislation that's happened over those years related to Medicare physician fee schedule, right? And the main thing that I probably want to point out here is obviously they've been going through a lot of reform on this over the years. And one of the big pieces that is embedded in all of that reform is alternative payment models, incentivized payment models that would pay a doctor more based on a healthy outcome versus just treating people in volume. And that's where this whole value-based care movement comes in. And we're definitely going to dive into that a little bit because there's some pretty interesting news that's come out about it as well. So this is a great article. If you want to dive in and really learn all of the details of how Medicare pays physicians, this article and this report from Kaiser Family Foundation goes through a ton of it, how it works, how it's changed. It goes through that decrease in the conversion factor and then some of the counters that they've made in it to stave off that decrease for doctors. And it goes through this whole list of other changes that have been finalized by CMS in 2024. And I'll highlight a few of those real quick, right? We've got new billing codes added to the physician fee schedule. And this allows clinicians to now bill separately for time dedicated to care coordination and direct patient care services. So anything from caregiver training, assessment of health-related social needs, coordination with community health workers, etc. So now they have these new billing codes that talk about, hey, I'm spending time dedicated to coordinating my patient's care, not just giving them direct care. So they got new payment codes there. They've also got a new add-on payment that allows clinicians to bill at higher rates for evaluation and management visits that are deemed to be complex, such as visits that are central to coordinating all of that care that I just talked about. So they have new billing codes for coordination of care, and now they have a new add-on payment system to allow them to bill at higher rates for evaluation and management under those complex situations. CMS also has new billing codes related to psychotherapy for crisis services, and existing codes can be billed by a broader range of providers. I talked about this several weeks ago, and this is a really good thing because Medicare has expanded their coverage through these new billing codes for psychotherapy, for behavioral health services, mental health services. That is always, I don't know if I wanted to say it's always been a shortcoming of Medicare, but when you look at the number of doctors that accept original Medicare, right, which is generally about 99% of them, that's doctors, providers, clinics, hospitals, etc., the 1% that generally don't usually fall in behavioral and mental health categories, psychotherapy, etc., right? Those are the doctors that generally haven't accepted it. We're looking at psychiatrists, psychologists, neurosurgeons, etc., everybody that's in that category, mental health counselors, family therapists, etc. Well, now they've got a new set of billing codes for that group of clinicians specifically to utilize to help them not only get reimbursed properly, but get reimbursed a little better. And because of that, we have seen a little bit of an influx in more providers that are in that space accepting Medicare again. So while I think the number is still touted that 99% of doctors accept Medicare, you could probably speculate that that has grown slightly, maybe half a point or so, with some of these new mental health counselors coming back to original Medicare with some of these new billing codes. So good stuff there, and I've talked about that before. Next thing they've done this year is they extended several telehealth flexibilities that were granted on a temporary basis during the pandemic, now through the end of this year. So there were a lot of different flexibilities that people were allowed to use because of the national health emergency, the pandemic, et cetera. And a lot of those are getting turned off, but no, they're going to push them through the end of this year and let them continue on. So these are good telehealth services for people that maybe don't have access to get into a hospital or doctor at a convenient location because maybe they're very rural. They live far out of town. So they're expanding some of that coverage, or extending some of that coverage, I should say. And then finally, they've added a health and well-being coaching to the Medicare telehealth services list, again through the end of 2024. This is to help folks that have social determinants of health risk assessments, right? So they've expanded all of that, and they're staving off again some of these cuts again through the end of 2024. Finally, it goes through some more info on how physician payments have evolved over time. It goes through some of the different legislation. And the one that it points out here, this was the first one, as I remember, right here where it says SGR was established by Balanced Budget Act of 97. I recently did recently, it's been a couple times over the last year or so, but a training and actually continuing education credits. I've done it for the Austin Association of Health Underwriters, now called NABIP, the St. Louis chapter, and I even did it at MedicareCon, but I talked about basically the future of healthcare, the future of Medicare, and I looked at healthcare reform going all the way back, and I found that in the Balanced Budget Act of 97 was the very first time that they created an alternate payment model to incentivize doctors based on healthy outcomes versus volume. That was the first time it's come, and this, you'll understand where I'm going with this as we get further into this session today, but pay attention to that. 1997 was the very first time that they created new reform that will push doctors, or incentivize doctors, I should say, for quality of care and the healthy outcome, right? The result versus just treating people based on volume. MACRA jumped into that as well. So, and then finally, it talks about the quality patient program that was established in MACRA, which is your alternative payment models I was just kind of speaking of, ACOs, et cetera. Concerns I mean, this is a really deep study that they did on Medicare physician fee payments. Like I said, I'm going to get it in the group. If you want to dive into it, you will definitely have that ability, and it's got some great links in it that can push you to some of these different reform acts, what the purpose of them was for, et cetera, et cetera. Moving along. FAQs about the Inflation Reduction Act, another great piece by Kaiser Family Foundation. I am not going to dive into everything, but if you have questions about the Inflation Reduction Act, what is it going to do? What is it doing? How is it going to affect prescription drugs? How is it going to affect your clients? Because it is going to have a huge effect, and I think a lot of people are underestimating it. If you look at it on paper, it sounds like a great thing, right? It's going to allow them to negotiate drug prices with these different drug manufacturers. It's going to create caps on prescriptions. All of that stuff sounds great, and I'm totally on board for that. However, the cost of all those reductions are getting passed to the insurance company, right? They're taking it off of Medicare's shoulders, and they're now giving it to the insurance company. So those costs just aren't evaporating. They're just getting moved. They're getting moved to the pharmacy manufacturer, right? They're negotiating drug prices with them to make them reduce the cost of their drugs. So they're getting some hit of it, but a big part of the hit is getting passed back through the insurance company, right? And I've been talking about this for probably the last 4 weeks on this show. We are seeing Part D premiums this year already jump way up to make up for the cost that they're not getting in prescription costs, right? One way or another, the company's going to get back their money, which means the client is going to have to pay for their drugs, whether they're paying for it through the prescriptions or they're paying more in the premium. It's just a teeter-totter, man. All they're doing is they're taking money out of this one bucket and they're moving it over here, putting it on the shoulders of the insurance carrier, which means they're going to get it back through premiums. And because of that, we will probably see some premium changes in Medicare Advantage plans next year. I don't know how else they get around it. Beats me. If somebody's smarter than me and can come explain why we won't see premiums go up or instated at all, because most of the Medicare Advantage plans that we sell are zero premium. So if anybody smarter than me is out there and can explain to me why we won't see premiums get included or go up for Medicare Advantage plans because of the Inflation Reduction Act, please bring it on. But I don't see any other way around it. Now, this FAQ sheet goes through a ton of questions. And again, I'm not going to go through all of them. If you really want to understand how the Inflation Reduction Act works, what it's doing, what its goals are, and how it's going to affect your clients more specifically in your practice, check out this article and dive through it. I will get it in the group. There are a couple of pieces that I want to point out real fast. And I have talked about this before, but these are the first 10 drugs that they are negotiating prices for. And these negotiations, once agreed upon or settled, they won't go into effect till 2026. So some of the effects of the Inflation Reduction Act we're already seeing, right? We're seeing caps on insulin, for example, right? We are seeing caps on out-of-pocket costs, et cetera. And we're already seeing that happen or affect Part D plans, as I mentioned, because we're seeing prescription or the premiums on the Part D plans go up. And again, like I said, I believe that's going to filter over to Medicare Advantage plans. That could have an even bigger, those effects could be bigger once these drug costs get settled, for lack of a better word. But these are the first 10, right? They are negotiating cost on Eliquis, the blood thinner, Enbrel, which is a rheumatoid arthritis drug, Farxiga, I assume is how that's pronounced. I can't think of any other way. That's another diabetes heart failure drug. Fiasp and Novolog is getting a big negotiation here. That's obviously one of your big popular diabetes drugs. Entresto, Imbruvica, Januvia. Man, I don't know if you got any people out there taking Januvia, but that one's expensive. Jardiance is another big problem there, another big diabetes heart drug. Stelara for psoriasis and Crohn's disease, and Xarelto, another blood thinner. So those are the 10 drugs that they're negotiating first. They are in negotiations now. Currently, if you look at the timeline, which I'll show you, I believe they're at the phase where all of the pharmaceutical companies are now putting together their counter offers to the first price point negotiation. The other thing that you'll see on this far right column is the Medicare spending for 12 months from June of 2022 to May of 2023, specifically on that one drug. And if you look at Eliquis, and if you're a Medicare agent out there, I know Eliquis is a big heartbreak for you. You hate seeing it in your prescription list for your clients because it's hard as hell to get covered properly with some of these carriers, and it is a pricey one. But look at $16 million, man. Doctors are handing out Eliquis like it's candy. But yeah, $16 million is Medicare spending on that one. The next costliest one is Jardiance at $7 million, Xarelto at $6 million, and so forth. So these are the first 10 drugs. Those are the ones that they're negotiate. It'll go through how that negotiation works. It goes through how they identify those specific drugs, right? How did they pick those 10, for example? And then it goes along through the timeline of activities, right? So right now is where we're at. CMS has already submitted their proposal. We are now waiting, right? We're right in this spot, right? So the manufacturers have responded with their counteroffer, and April 1st is the deadline for CMS to respond to the manufacturer's counteroffer, and we'll see where they're at. So they're allowed to have up to 3 meetings during those counteroffer negotiations until finally they get through implementations, agreements, and this thing goes into effect January 1 of 2026. And then it'll continue on from there. Once they get those, they'll go through the next 10 and then the next 10. There are a total of 100 drugs that they want to renegotiate prices for. This is just the first 10. So this is going to go on for a while and will certainly be a big source of probably frustration, confusion, and likely some bipartisan arguments. So a lot of great information there. I will get that in the group as well for you. And just moving on, I've talked about this quite a bit, right? We've talked about Humana. We've talked about Anthem. We've talked about Aetna, United Healthcare, all of them saying that, hey, we are losing money. And here's another one that just came out. Providence improves in 2023, but still posts a $600 million net loss. Providence is a big MA carrier down in South Texas. They're a nonprofit MA carrier. I know some agents down in South Texas that are using them and love them, service, et cetera, et cetera. But if you look right here, it says, hey, man, Providence posted a $1.2 billion operating loss for fiscal year ended December 31st. Wow. They performed a little bit better in 2023 than 2022 when it posted a net loss of $6.1 billion and an operating loss of $1.7. But man, these guys are losing money. Providence operates in 51 hospitals, more than 1,000 clinics across 7 states, reported operating losses every quarter in its fiscal year of 2023, even while implementing a financial recovery strategy. You can go through this article and look at it a little deeper. It'll explain how their money gets divided up, where they're spending it, etc. And then probably one of the most important notes in here, credit rating agency Fitch Ratings assigned the operator an A long-term outlook, signifying expectations of low default risk on approximately $8.2 billion in outstanding bond debt. However, it did affirm their negative credit outlook. So I'm not sure what's going on with Providence. They are definitely losing money. Doesn't look like they're going to come around anytime real soon, especially with the negative credit outlook. So I'm not telling you to quit selling Providence because every one of these MA carriers is out there losing money right now. And they're probably going to get a cut from CMS this year, which means they're going to lose more money, which again means that what are we going to see? We're probably going to see reduction in benefits. We're probably going to see some premiums added into MA plans. I expect the AEP of 2025 coming up this October to probably be the most chaotic AEP we've ever had because we will definitely see what's shaking down with these plans, and there will likely be a lot of movement this year, which is good. I mean, it's good from the aspect of, hey, it creates opportunity for you as the agent, right? Because anytime there is a significant amount of challenge, confusion, and problems in an industry, that creates a lot of opportunity. So again, if this AEP is going to be one of the biggest shakeups out there, get ready. because it's going to give a good chance for you, if you're ahead of the curve and you're paying attention to these things, attending your plan rollouts, really taking notes on what your plan changes are, what's going to be affected between the Inflation Reduction Act, the possible reduction in MA reimbursements, which we're likely going to see, and then all these carriers losing money. If you're ahead of the curve and you're paying attention to all that, you could go out there and scoop up a lot of business this AEP. So buckle your seatbelt. Moving along, and this kind of plays into it a wee bit as well. Boom. Another article from Kaiser Family Foundation. 3 questions to ask about Medicaid unwinding, what we know and what to expect. Whether you're an ACA agent or a Medicare agent, you have likely been affected by the unwinding of Medicaid and all the number of people that they have been booting off of Medicaid. And if you're wondering, first of all, why did that even happen? Well, the Medicaid redetermination happens every year, but during the public health emergency of COVID that started in 2020, they staved off Medicare redetermination. So instead of redetermining every year who's eligible to keep Medicaid and who needs to get booted off, they said, no, we're just going to keep everybody on Medicaid that already has it, and we're going to delay this redetermination until later. And now they're doing that redetermination. They've been going through it. I want to say it started June 1st of last year, if I remember correctly. And they're maybe about halfway through so far, plus or minus. So it tells you right here, it says, hey, overall Medicaid unwinding has declined nearly 10% across states since the start of unwinding. So, right, so it's going down. But it also says that the national decline in Medicaid enrollment masks variation across states. And obviously every state's going to be a little bit different, right? Because some states passed Medicaid expansion or adopted it, some states didn't, etc. So some states you're going to have a very big effect in Medicaid unwinding, and some states and not so much. The piece that I really wanted to mention in here is this one right here. Number 2, where will Medicaid enrollment wind up at the end of the unwinding? So, and I'm just going to read this little paragraph to you real quick, but it says it is highly uncertain what national Medicaid enrollment will be like at the end of the unwinding. With about half of the renewals still left to complete, Medicaid enrollment will likely continue to decline. However, it is unknown how many of those who are procedurally disenrolled will regain their Medicaid coverage and how many new enrollees may come onto the program. During the pandemic, Medicaid enrollment increased by 23 million or 32% from the pre-pandemic levels. Given that unwinding is about halfway over, judged by the share of renewals that have been conducted so far, it's possible that Medicaid enrollment could end up roughly at the same level it was before the pandemic. In some respects, this could be considered a success. The continuous enrollment provision was intended as a temporary measure to ensure people didn't lose Medicaid during a public health crisis. A return to pre-pandemic enrollment levels, not an unreasonable outcome, particularly in an environment of low unemployment. However, those pre-pandemic Medicaid enrollment levels are not necessarily a good baseline for measuring success. Roughly 1/4 of people who are uninsured are eligible for Medicaid and not enrolled, suggesting that Medicaid was not reaching everyone who could be helped by the program before the pandemic. And while there was a churn prior to the pandemic, and some churn is to be expected, rates may have been too high, resulting in eligible people losing coverage for short periods of time. Yada, yada, yada. In short, it looks like we're just going to end up right where we were right before the pandemic, right? They increased Medicaid through the pandemic, let pretty much everybody have it. It jumped 23 million or 32%. And it looks like, based on this unwinding, we're going to get right back to where we were. So not necessarily, and they kind of argue here, is it a success? Yeah, it could be considered a success, maybe not. And again, it's going to be affected in different states. And that's kind of what this next little blurb here talks about. It talks about a couple of key states, South Dakota, North Carolina, that implemented Medicaid expansion, et cetera, and so forth. So another good article. I'll get this one in the group, man. If you're an ACA agent out there, and you are counting on people who are losing Medicaid but still qualify for subsidy to get them enrolled, good information for you. And if you're a Medicare agent who deals in the DSNP space and you got a lot of clients losing their Medicaid and trying to get requalified for it, another good piece of info right in there for you. So look for that in the group. Boom, boom, boom. Is that? Yep. And then we come to my key piece. All right. Ooh, so if you follow me much and you hear some of the stuff I talk about this quite a bit. And this was a big key component of the talk that I did at Medicare Con and the continuing education pieces I did regarding the future of Medicare. It really highlighted the move to value-based care. Value-based care is blowing up. It's been blowing up for a while. It is absolutely enormous. There are more value-based care providers coming into the business. And some of them, like Oak Street, right, is absolutely huge, big enough that they got bought out by CVS for, I don't remember what the price tag, but it was a very, very large, I want to say 10-figure price tag that they got for that. So this article is going to go through why we're going to see some big developments to look in 2024 for value-based care. And I'm not going to go through the whole article, but I am going to point out a couple of things. If you don't know what value-based care is for any reason, value-based care is an alternative care model that incentivizes doctors based on the value in the care they provide, or more importantly, the quality of care, more importantly, the outcome of the treatment that you're getting, right? So is the quality of care resulting in a better healthy outcome for you to prevent chronic disease, etc., or is it just a volume play like most doctors with the rotating door where people come in and out? Doctor sees them for 5 minutes, gives them a prescription, and sends them on the way. Right? Value-based care is a different model that's looking at how do we incentivize doctors to cure people and get them healthy and prevent chronic disease versus just treating chronic disease in a volume play all the time. So when a doctor has a great experience and he's able to cure someone or give them a better healthy outcome in whatever their situation is to help prevent chronic disease, he makes more money, right? And I mentioned this a little earlier. This is why I mentioned the Balanced Budget Act of 1997, because that was the first time that Medicare included any reform to incentivize doctors for alternative payment models like this. And then over the years, we've seen numerous changes, right, or reform laws that continue to push towards this direction, right? Now, just to go ahead and say it, I believe that somewhere probably around 2032, 2034, somewhere in there, sometime after 2030, right? So, somewhere in that ballpark, we are going to see a massive shift in our healthcare industry, which will probably be something that looks a lot like, or is, universal healthcare. And I believe what they're going to do is they're basically going to merge the ACA world and the Medicare Advantage world into a universal healthcare model backed by value-based care. I could be completely wrong, and I would love somebody to point out why I'm wrong. So far, nobody's ponied up any information to disagree with me on it. But if you look at the trajectory of all of the reform that Medicare has been doing since 1997, they keep including little pieces of legislation that push to this model, right? That expand this model, that get more doctors involved in this model. The macro legislation that came out in 2010, if I remember right, was a big part of it. And a lot of people, a lot of Medicare agents that look at macro, they're like, no. Macro was just there to reshape the Medicare supplement plans, right? It introduced some new things about the Medicare supplement plans, got rid of plans H, I, and J, and modernized them, so to speak, whatever you want to say. That wasn't all that MACRA did. MACRA included a key piece of legislation that expanded the value-based care program and the MIPS, Medicare Incentivized Payment Structure, I think, payment system, I believe, yeah, which again incentivizes doctors for healthy outcomes, right? So if they can create a healthier outcome for you, they make more money, right? So this little paragraph here kind of explains it. The goal of value-based care is to promote better care for individual patients and improved healthy outcomes for communities at a lower cost. This is an important and admirable purpose as many VBC stakeholders attempt to tackle inherent challenges within the healthcare sector. In 23, VBC grew and evolved as healthcare providers, payers, and policymakers sought to improve patient results while containing costs. Expect to see more of these same investment trends in 2024. And I've got a little bit more I want to hit on this. I can't remember the quote exactly, but it basically says something to the effect of, if we can learn to incentivize doctors based on quality of care versus volume, then it stands to reason that the quality of care should go up. Seems to make sense to me. I'm actually all on board with the value-based care model. I think it's ingenious. If they get it to the level where I think it should be and could be. And the way I look at value-based care is very simple. I look at it like this. If I have, and we're going to talk it from the guise of a Medicare Advantage plan, but this would spill right over to ACA, 100%, and could easily, in my opinion, create a universal healthcare model. You have your Medicare Advantage plan, right? Whoever your card is, I don't care if it's with Aetna, Humana, WellCare, whatever it is, right? You got your little card. That card not only has a network of doctors and providers and hospitals and clinicians, right? But it has a network of grocery stores, healthy food chains, whether it's Whole Foods, Central Market, whatever it might be, right? That's included in that card. When you shop there, you get a discounted price for buying certain healthy food items. When you buy the organic bananas, for example, you accrue some points that add up on your little card. And as you accrue points, you can use it for any variety of items. Maybe you can use it to offset your doctor and doctor co-payments or your provider co-payments. Maybe you could use those credits to pay for your over-the-counter items. So I think they're going to build in a reward system based on you choosing healthy alternatives to take care of yourself. So if I go shop at Whole Foods and I buy the organic bananas, right, and the good food for me versus ding dongs and Twix bars and soda pop, I'm going to earn credits on my little flex card now. And those credits can be traded in for services that I need to reduce my costs, right? Gym membership, same concept. They're going to include a gym membership. They're already doing this, right? Silver Sneakers, Silver and Fit. I can't think of the one that United Healthcare calls it now. I forget, but they've all got their own little fitness programs that they have. They give you discounts at fitness gyms. Well, now they're going to amplify that. And inside of that, they're going to say, hey, instead of just giving you the gym discount or the free gym membership, we're going to incentivize you to use it. And now when you use it and you go to the gym and you show up for the yoga class, or you go and you show up for the Tai Chi class, or you go and you show up for this nutrition class or this fitness class, guess what? You're going to get more points earned for your little flex card. So every time you choose to do something that pushes a healthy outcome for you, you go get a mammogram, you go get your PSA test for prostate cancer, you go get your physical, you get your colonoscopy, you go to the Tai Chi class, the yoga class, you buy the organic bananas, we go to the nutrition class, you go to this 101 class, whatever it might be. Anytime you do that, the patient gets incentivized and builds credits, and now they're gamifying the healthcare system. Because now every time you use your healthcare in a healthy way, use your plan to help keep you healthy, you're earning points, you're earning credits, you're building up your score. And then every time you hit certain levels, it's going to unlock rewards for you. That's where I think we're headed. And I believe it will be, I believe it'll be a much better healthcare model than what we're used to personally. And I think a lot of people would agree with that. Like, I mean, when the last time you went to the doctor, think about it. What did you do? You walk into the doctor, you check in, you sit in the lobby for 15, 20 minutes. You talk, they check you in. The nurse does. She pulls your chart, asks you a few questions. She might weigh you. It seems like they always love to weigh me every time I go in there. They check your weight, right? They put you in a waiting room. She talks to you, maybe checks your blood pressure, a couple of other vitals. You spend more time in the waiting room than that nurse. And then the doctor comes in. He has your chart. He looks at some of the notes the nurse made, right? Says, hey, those moles are looking kind of weird. You should probably lose some weight. Prescribes you something, and he's gone in 5 minutes. He's busy with another patient. He doesn't have time to really care about you. He's like, okay, nurse said this, this, and this. You're complaining about this. Well, let's give you some of that and then send you on the way, because he doesn't have time. He's got another patient that's in the next waiting room. Value-based care says, hey, we need to look at it different. And if we can incentivize these doctors to spend more time with their patients, to incentivize them to create a healthy outcome for their patient, then that should create a better model of healthcare. And then the next level is then incentivizing the patients to utilize their plan in a healthy manner that helps keep them healthy and stave off chronic disease. So last year, I'm going to continue on this article some. Last year, healthcare providers continued to move away from traditional fee-for-service models. What is a traditional fee-for-service model? The Medicare physician fee schedule, original Medicare. If you don't already know that, original Medicare is a traditional fee-for-service model. Every service has an agreed upon fee, regardless of what it is, right? Doctor does this, this is how much original Medicare pays. So last year, again, healthcare providers continued to move away from traditional fee-for-service models in favor of alternative payment models, such as the use of bundled payments, capitation and shared losses, and savings arrangements in an attempt to deliver a high-quality, cost-effective services by linking payments for those services to the actual outcome. What happened to the patient? Did they get healthier or did they not? And if we saw an improvement in the patient's health, doctor gets paid more money. I like that idea. I want my doctor to be incentivized to keep me healthy versus I don't have time to see you, Mr. Merwin, because I got someone else here. There's a prescription. Go to the doc, go to the pharmacy, get some sleep. You'll do great. Don't forget to eat your carrots and lose some weight. Like that's the best you get out of them. But these VBC models, maybe I'm wrong. Again, somebody come tell me why I'm wrong, but I don't believe that I'm looking at this through just rose-colored lenses, so to speak, right? It goes on to say that the trajectory for growth of VBC in healthcare, however, is not a straight line. For all the industry chatter about the 2030 deadline established by Center for Medicare and Medicaid Services to transition the vast majority of Medicare and Medicaid spending to accountable care, real progress toward meaningful shifting existing care models have been slower than expected. Where did I get that 2030 number at, right? They have a deadline to try to get the majority of all spending pushed to a VBC model through accountable care, right? They were trying to do this a long time ago, and it was really early. I can't remember the exact date. I have my whole list of reform. I should have brought it with me, but there was a reform made in the early 2000s, if I remember correctly, that stated that, hey, our goal with this reform is to move at least 16% at the time of all Medicare payments, reimbursements to doctors or healthcare providers to a VBC model, right? And now they're looking to get it even further along. And the deadline is 2030 to hit their goal. So here's the big one. Right here is this article. There are probably the next two. Payment models expected to transition to VBC at an even faster rate. No kidding. Expect an even faster shift towards how healthcare services are delivered and paid through risk-based contracts and other alternative payment arrangements that prioritize outcome over quality, or outcome and quality over sheer volume, right? So the only way a doctor currently makes more money is through volume of patients. I got to see a bunch of people. He's like a waiter in a restaurant, right? The more tables I can turn, the more money I make as a waiter. Doctors in that same spot. I got to turn people over. So they want to flip that, and they want to prioritize outcomes and quality. If the doctor delivers good outcome, delivers quality, he makes more money. This transition is steering the industry towards a more patient-centric approach as providers focus more on preventative care and the overall health and wellness of each patient. Hallelujah. It sounds great to me. The projected growth of VBC from $500 billion currently to a potential $1 trillion underscores this momentum. They're projecting it to double. They don't give a timeline. I mean, they say it's going to grow in 2024 big time. So I don't know if they're saying it's going to double in 2024 alone. Yeah, I don't think that's the case. But they're expecting a huge growth again. It's already grown like crazy. If you go back and you look at the growth of Oak Street, one of the biggest ones out there, their explosion is absolutely out of control, right? And we're going to see the same thing from some of these other VBC providers that are out there. And then right there, they're saying like, look, it's going to grow to a $1 trillion business. So the combination of increased patient engagement, along with the development of newly refined contractual and financial arrangements suggest that the evolution of VBC will be at a tipping point this year. Check this stat out. Nearly 70% of Medicare Advantage enrollees opted for a VBC provider. That was back in 2022. That wasn't even this year. 70%. I think there's 33 plus or minus. There's about 33 million people enrolled in Medicare Advantage. And 70% of those people, which is about 21 million, are all enrolled in a VBC provider. Oak Street, Suvita, WellMed, it goes on, right? So that's the main point that I wanted to point out there was it's growing fast. Everything that I've talked about at Medicare Con last year seems to be coming true. Everything that I've talked about in these CE classes on this stuff seems to be coming true. I'm not going to go through the rest of it because it's talking about technology and so forth. But again, and hey, and if you're an investor, like you might want to look at some VBC companies to invest in. I don't know. I'm not a financial advisor, but it's going to continue growing. And if you're like, hey, man, how do I help? How do I get involved? This is a tool that I just found. I have not enrolled in it yet, but this is the VBC Finder. Now, some of this is already pretty easy to find, and a lot of the good VBC providers that are out there, like Oak Street, like Suvita, they are proactively reaching out and building relationships with insurance agents, insurance brokers that are working in the Medicare space because they understand that need for that relationship, right? We want to be able to refer people to VBC providers if we believe in them and we think it's going to be great for our client, and they obviously want to pick up clients. So this little tool has come out here, which is pretty straightforward. It's the VBC Finder tool. So this is going to help connect seniors to different VBC locations. Like I said, I'm not here endorsing it. I'm not using it. I actually just stumbled across this today when I was just kind of bouncing around looking at some of this VBC stuff. This very well may be a phenomenal tool that brokers can use, but it says right here, hey, VBC Finder helps you connect seniors with nearby doctors who accept Medicare with the most up-to-date information on providers, healthcare organizations. We can help you match patients with primary care doctors based on their healthcare needs and preferences. So if you like VBC, you're into VBC, this may be a good thing for you. Check it out. And that is pretty much it for that. So I've been talking about quite a bit of stuff. I see some excellent comments in here. I'm gonna sit here and keep talking. I'm gonna thumb through some of these comments and see what I can find. Can I share that list? What list was that? You'll have to remind me. I'm gonna make sure any of the articles that I put on the screen today, I will get in the group. So look for those. But other than that, the problem, what's he saying here? The problem with this from a doctor standpoint is they don't want to treat really sick patients. What will happen to those patients? Well, how do I say this nicely? I don't know that it's that. I don't know that it's that they won't see those patients. If they're incentivized, and I'm speculating here, I will definitely get that drug list out there for you. I'm speculating a little bit here, but if the doctors are incentivized to help that person become less sick, then I would hope that the doctor follows his pocketbook and treats him the best way that he can. So it's a good question. I can't imagine that all of a sudden just sick people are just going to get pushed to the wayside. But the idea, and I believe this is true, the idea is that moving to a value-based care model with an alternative payment system that incentivizes doctors, it's going to create a healthier society. Now, I'm of the opinion that I believe we are already approaching a healthier society because I believe there's a little bit of a shift happening in a lot of our mindsets. The people it seems like healthcare or self-care, healthcare is becoming a really popular trend among people as we get older. I'm finding a lot more people really interested in taking care of themselves better. People seem to be paying attention a little bit more of what they eat, what they drink, what they do, etc. I don't know that is critical mass thought process yet. If we know the rule of critical mass, it's definitely not, because we know the rule of critical mass. It says that once 51% of a mass all start thinking the same way, then it just spills over to everyone. So we're definitely not there yet. But I mean, go look through your Facebook friends list or look through some of the posts. Like, how many of your friends are now taking their health much seriouser as they get older? Is that going to continue? I don't know. I mean, I see a lot of things that are changing out there. Like the size of Coca-Colas are shrinking, right? There's all these different healthy drinks and energy drinks and things that are out there that it seems like it's trying, that people are waking up, so to speak, for lack of a better phrase, to their health. So I feel like the future could definitely be a healthier society in healthcare through a VBC model as well, right? If we're learning to take better care of ourselves. What do we say here? VBC clinic providers have no hospital rights. They also aren't open on weekends. They aren't open on President's Day, etc. When clients have an emergency, hospital doctors don't want to touch them. That is a fair point. That I think that'll probably be something that has to change in the future, right? I think that's just going to be something that has to change. I know VBCs aren't set up for emergency conditions, right? That is a hospital emergency room. So that's likely their thought on not being open on the weekends is like, hey, we're not set up to treat trauma and emergencies. People need to go to an emergency room for that. We are here for acute care, chronic care, preventative care, and primary care, right? That's what VBC models are for. So we may see them reopen or start opening on the weekends. But again, you have to understand they're not there for emergency care, which really wouldn't necessarily require them to be open on the weekends, in my opinion. So I don't know that that's such a big deal. And again, I will get that drug list out there for you. So with that said, man, thank you guys for tuning in. A couple of quick announcements real fast. I just want to say a few things real quick. Number one, there's a lot of events coming, man, this spring and summer. There's a lot of events. If you're a Medicare agent out there and you're not going to Medicare Con, you're missing the boat. I know they are close to selling out on tickets. Get your butt to Medicare Con. It is the best conference for the Medicare agent that is exclusive to Medicare, right? And it is not just a hype weekend. It's not a weekend that wherever you're going to get recruited and sold. Like, this is high value content from people in the Medicare industry that know what the hell they're talking about. I get to host the conference. It's a blast for me, but I definitely look forward to seeing you there. If you are a bilingual agent, no matter what line of business you're in, I don't care if you're in Medicare, property and casualty, ACA, life and annuities, etc. You need to get your butt to Invictus. That is coming to Houston May 1st, 2nd, and 3rd. You will see that conference. That is the full Spanish language conference. Everything coming from stage, everything taught in the breakouts is in the Spanish language. You guys can use whatever language you want in the lobby, doesn't matter. But understand that if you want to understand what the value that's coming off of that stage or in the breakouts, you either better understand Spanish or get you some of those little translator earbuds like my buddy Sam Wolf had last year. I saw him sitting in the front row, had his little translator buds in. He said they work great, and he was able to understand everything. So, yeah. Get yourself to those events. I hope to see you there. I have want to just announce next week's show a couple of times, and I think it was maybe 3 or 4 shows ago, somewhere in there. I don't remember exactly, going off my memory, and as I get older, my memory fails over and over. I talked a little bit about communication and the 5 steps to a conversation. I am going to, next week, I am going to take those 5 steps and we are going to put them into real world practice. So my goal is to take those 5 steps and help you build an appointment setting script using those 5 steps. That's the primary one. And I will probably come up with a couple of others, maybe seminar, maybe a couple other things, but we're basically going to take, hey, here's the 5 steps: introduction, short story, presentation, close, and rehash. But we're going to actually say, okay, Tony, we heard your outline, but actually help us put them into practice. So we're going to put them into play and how you can use those, understand them, and write your own appointment setting script, write your own seminar meeting, whatever you want to do. But we're going to do it real world, right? So get excited, bring some notebooks for that one. And then other than that, man, that is it for the day. So thank you all for tuning in. Have an awesome, awesome rest of your Tuesday. We'll see you next week.